I think we're good to go. Hello to everyone in attendance and welcome to Better Together, Why Partnerships Are the Future of Health Tech. I'm going to be your host today. My name is Eitan Gaffney. I work at LabOS. And today's session is a special one for us because we are joined by one of our partners in crime. No, I'm kidding. And today we're going to talk about basically what it means to have a tech partner when you're a vendor. And if you're not a vendor and you're a lab or a medical facility, why you'd actually want your vendor to have a third party, let's say technical partner. Now, before we begin, let me just remind everyone that this session is recorded, of course, and we'll send the recording to everyone in attendance or everyone who signed up and couldn't make it, so you'll get it in your mail. And the other thing to remind everyone is that if you have any questions, we'll have dedicated time at the end, so just please use the chat, this platform's chat, to ask your questions, and at the end, we'll come back to them. So basically, what we're going to address today are three main questions. You can see them on the screen, so I'm not going to read them out loud because we all know that's less productive. But these main topics are topics that I believe every medical facility today needs to ask themselves. So this is what we're going to talk about. Now, before we begin the session, and I'll introduce our speakers, I just want to ask how many of you watching this right now live and in the recorded version, how many of you have felt this specific quote that you're seeing right now? That most healthcare failures are not caused by bad technology, they are caused by isolated technology. Now, I'm going to take a wild guess and say that most of you have felt this, or most of you can sympathize with this statement. And this is exactly what we're going to talk about today. Why this happens, how can you avoid it, and some main takeaways and key insights. So let me just clear the stage right now and give the stage to Gilad Brand, our first speaker. And after Gilad, we'll have Jack Redding from PreciseMDX. And each of them are going to share some horror stories, let's say. And then we'll dive into more key insights and maybe draw some new conclusions. So Gilad, the floor is yours.
Okay. Thank you for that. So hi, everyone. I'm Gilad. I am the lead business development and marketing and sales here in the team in LabOS. I've been with the company for the past, I want to say, 17 years. I started as a programmer, then moved into the product management, did then implementation projects. So I kind of know the lab inside out, from the business aspects, from the technology aspects, and to Eitan's questions, I've seen quite a few isolated technologies, and we've helped bridge those gaps, whether with innovative solutions or just by partnering with strong partners. So I want to tell you a little bit about LabOS, the company we work with. So we've been doing this for over 30 years. We're an LIS, the Laboratory Information System. We are an AI-driven, cloud-based. Even though we are a company with a solid track record of 30 years, we've always kept up with the most current technologies, and we're very proud to say that, if not the only, but we're from the top cloud-based LIS vendors out there today. You can get it as a software as a service. Our LIS is a one-stop shop for cross departments. We do all type of department and laboratory work, and it's a customizable SaaS platform, seamlessly connects every lab department with the ordering facilities, hospitals, catering over hundreds of clients worldwide. It chose LabOS to maximize their growth and achieve streamlined operations throughout using technologies, which helps the labs just focus more on analyzing, testing operations, where they don't have to just work through their workflows and struggle with the technology. So today we want to talk a little bit about some horror stories that might be a bit dramatic, but just, for everyone or anyone who was in the lab space knows that, as we mentioned, interoperability and different various workflows vary. Each lab does things a little bit different, and just connecting all the pieces together from a patient-centric point of care technology can have its challenges. So the incident was a standard digital ordering system implementation faced operational issues post go live, despite the correct technical configuration. Meaning we were interfacing. This was a hospital where we were responsible for the lab work, and all the ordering and was handled by different technology, different system. So, and the root cause for the issues that we encountered, which we'll dive into a bit later, wasn't software bugs, but just more unmapped environmental complexity, workflows, kind of things and work procedures where they were by heart, or just the way things people were doing wasn't well documented. And then just the workflows kind of got cumbersome. And the cure was introducing independent architectural governance layer prior to the vendor engagement. So when simple requirements meet complex hospital reality. So as I started mentioning, we were talking about a large public hospital with over, I think it was maybe 1,500 beds, where they had different departments in the labs, but were piloted and required to kind of cater for just one of the departments. If it was chemistry, the chemistry lab. So we did the standard implementation where the simple requirements that were presented were, hey, this is our system, our internal. They had a homegrown system where they developed the way they order the test. They want to send it over to the lab. The lab performs the work, uses our technology, our LIS, to just result, have the ruling mechanism, have all their triggers, everything set up. Once it's ready, the results are ready to be released. They said you send it back to this ordering system, and the ordering system just takes care of everything. And that was kind of the simplified requirements where we had. So for us, that was kind of a walk in the park where, easy for us to just receive an order, distribute the results, just another day, as we like to say. The pilot was very successful, and they wanted to push for the go live. But once we went live, that's when kind of the unexpected operational issues occurred. What actually happened? We had some duplicate result releasing, two valid distribution rules, general and department specific. And so the results were sent twice, meaning our system knows how to handle very complex distribution rules. So once these orders were processed through the lab and the result entered, our internal system distributed it already to the repository, to the ordering system. However, we have a policy where we know how to distribute by each result that comes in, and we have all kinds of policies if someone wants only to get the results when the whole order was performed, or just each department. And that part of the pilot, when we weren't working with the live system. So the two main differences were, first of all, not all departments distribute and release their results the same way. So in certain instances, we release the results, and then the other system that we were interfacing with, the ordering system, also decided to distribute some results when we hit them back. And the other thing was just the sheer volume, in a pilot, or when you're working on one isolated department, you're testing, you're validating, you're doing everything, but it's just not the whole, nuts and bolts. It doesn't go from A to Z, just where we was testing the certain workflow, which worked too good if you want. And the sheer volume is just the duplicate release of these results just caused some, let's say, stress on the system. Lab device mapping, because we were implementing and working on this pilot in several departments, then there were some niche parts of the catalog and tests that the lab offers that weren't mapped at all, just in the system, which in the incomplete test mapping created the results not returning from the instruments, but they were pending there. We do have a exception handling process and mechanism where you can find that. So we found that pretty fast that just, okay, this department who didn't do, I would say, weren't working hard enough in validation just to make sure that all the tests and everything was mapped. So those kind of also were a snag on the first 2 days where we were finding these results. And some background job ran on different servers just because we do it in hospital environments. We like to have redundancies, and also one of those processes kind of contributed to us just sending, not us, but the system sending the results twice. So that's kind of just the description of what technically happened in this project, but the real root causes of when we did our postmortem and the debrief, then we said just the requirements were oversimplified. You know, they said, okay, we send you the order, you just release us the results, and our system will take care of all the rest. We found out that that wasn't the case. The cross-lab dependencies were not fully revealed in MAP, just as I kind of described, where certain departments work a certain way, but the other departments work differently, and just those and piecing those departments across workflows, just that some things weren't, some I's weren't dotted, if you will. And just the regulatory workflows were severely under-communicated, meaning when we had rules of exception handling on certain results that need to be sent out, so when we sent them twice, and you know, one might think of it just as a bit wasteful, but regulatory workflows just said, no, you cannot send a result twice because then they think it was performed twice, some technical issue like that. And infrastructure topology was not fully reviewed. Again, this is in a hospital setting when you're piloting on a department or two. It's just you cannot make assumptions that everything is connected and oversimplified. So what would the third-party partner should have been involved? So in our when we concluded this, though, a governance and monitoring platform that sits above our platform, meaning we're more our LIS, as I mentioned at the beginning of my time here. Our bread and butter is the laboratory workflow, the technology, just streamlining operations on the lab's production floor, documenting this, the regulatory and just the workflows across the hospital that have less to do with the lab isn't our expertise. So it was our conclusion that our governance, just the platforms for someone to come in, even prior to us coming and setting up and doing all the technical work, that would have been helpful. So the text configuration and overlaps before go live, simulate workflows, and just kind of the legwork of kind of documenting what is actually going on all around the lab and not just on the production floor would have been very helpful to just not hit these challenges. Not invasive, read-only, no code changes, nothing technical, just kind of to come and help us with documenting the processes. Partners should have entered through the hospital first before implementation to map all the laboratories, identify the overlapping, just kind of, this is a short summary of what I've just described on the previous slide, but audit the infrastructure and the redundancy and document the real operational workflows. So talking about great partners that can come and help with the lab's work and all everything around it. So I would like to introduce Jack from our partners from PreciseMDX.
Hello, I'm Jack Redding. Glad to be partnered with LabOS folks. I originally started being a competitor of them. Then many of my clients use them quite happily, and so I'm very happy to be partnered with them. Real quickly about me, been, I say, stuck in the lab business for 40 years, being a programmer, making my way up, working with large commercial labs and hospital labs. When the folks of LabOS reach out to me and say, hey, would you mind doing a webinar with us about what makes a good partner, kind of thought is like, there's a lot of things that make a good partner. There's a lot of bad things. So we put together kind of a horror story. It's when I was vice president of, go to the next slide. Please stay there a second. Um, um, so our horror story is going to be when I was actually vice president of a large commercial lab acting under as a lab outreach program in New York City, and kind of what are the good things in a partner, what are the things that I learned specifically on when you're working with your vendors, being a lab, what's the best way to manage the process so the outcome is good for everyone, and most importantly, the patient. I'm the co-chair of an effort called Clinical Lab 2.0. It's an effort, actually, our annual meeting is this weekend, and try to get labs a bigger role both in the government space and the payer space, because what labs do is so important. And we're still kind of in Lab 1.0, where we're just fee for service, and we're trying to raise the level of lab industry. And then also, I was heavily involved with the FDA with healthcare cybersecurity for laboratories, especially in the hospital world. It's kind of messy, and the FDA was trying to figure out best way to protect health information. So my background is heavy on running laboratories, IT, and I hope to bring some of that experience in what we're going to talk about. Next slide. So my current role as partnered with LabOS is with PreciseMDX. And we have a bunch of, I call, really cool technologies that work really well, from even your mid-sized labs all the way up to some of the largest labs in the world use us for AI, portal workflow management. So we call it solutions for modern laboratories. So if you want demos, you can hit me up later, but real intent today is to talk about how best to run your laboratory when working with different vendors. Next. So my horror story, this was 2020. So think COVID was raging really, really bad. We were a very large outreach program in the New York metropolitan area. We had physician practices, nursing homes all over the area that relied on us for laboratory testing. We'd interfaced with all their different EMRs. We were competing against the two large national labs, which interfaced with their clients, so we had to do the same. And in order for them to use us as the hospital lab, they're like, we don't want to, go backwards. We have to be interfaced. So we reluctantly did the interfaces. At the same time, since we're hospital-based, they were moving from their current EMR vendor for the whole system and replacing all the systems, including the lab. So we called it, we're flying the airplane as we're building it. So we're trying to bring on new accounts as we're trying to shift from one LAS to another. Next slide, please. So as we went out and we would go to the different physician office, we found that every clinic had a new custom build, which means like an order in interface, results back out. And the ongoing maintenance, upgrade, retesting, it was just absolutely painful. Because we had an older system, we were doing many, I call them peer-to-peer interface, or the traditional VPN HL7 interfaces, which take a very long time, very expensive, and they never seem to get done because you're always updating your test code directory, your physician list, and they're just a nightmare. And all you're basically trying to do is get clean orders from the clinics and the physician office and get the results back. The leadership at the hospital, which is basically the CIOs, were hesitation to allow us to grow because they knew these projects were a pain to do, but you weren't allowed to get new offices unless you actually did the interface. So we're kind of stuck. You want to bring in the revenue, but you had to interface with them. And then my teams were just burning out, just trying to keep the physician expectations in check. They would want the interface tomorrow, right? And to do a VPN with an HL7 interface takes months and months. And many of the EMR interfaces weren't supporting APIs. So even if we could offer an API, it was not feasible to do based on we were trying to implement a new LAS at the same time. Next slide. So at the same time, we were out there trying to grow the physician business. We'd run to EMR vendors and they would say, well, you have to be a certified integration partner with us. And they would try to sell us their toolkit. And so once again, I was trying to manage expectation with these vendors, and everyone had a different contract, a different BAA. It was just very, very difficult. And we were basically saying, we're the hospital lab, you need to work with us. And we had our own approval queues. We had to go to different levels of approval and fees just to get the projects done. Every project was a custom installation. Interoperability wasn't even really talked about then. Became much more in vogue after COVID. And at the end, we were just basically saying to the physicians, can you just fax us in the orders? We'll scan them, and we'll do them by hook or by crook. The AI that we have at PreciseMDX wasn't available yet, so we had to do everything manual. Next slide. So when we embarked on changing LASs, this was a representative document that we had shared with the vendor. And so you see we have different ABC clinic had a particular EMR that only supported HL7 2.5.1, long-term care facility wanted to do an API. Another EMR had HL7 2.3. An external EMR had a proprietary interface. So we had a whole list of the catalog of the interfaces. The one that we forgot was our reference lab interface, which will become important to my story in a little bit. So we met with the implementation folks, like, okay, no problem. And the one very junior analyst said, well, aren't all these orders already in the EMR? And it was like, they clearly didn't understand outreach. I was like, no, these are coming from the physician office. They're like, well, why can't we just give them the EMR? And it was a bit education. And, so we were very patient with them, but we helped them quickly understand is like, all these interfaces need to work because they work now, and in the new world, they need to work seamlessly, and which my story will unravel, and they didn't. So next slide. And these were the reasons why it didn't. Each of these interfaces supported different formats. Different custom Z segments were used for insurance information. Even though HL7 is supposed to be standards, the ORMs are different than the ORUs from vendor to vendor. Some of the EMRs, we had LOINC mapping done, and the vendor that we're moving to hadn't even considered as part of scope of the test code directory of the hospital LOINC mapping in. The physician IDs, if it wasn't a physician that was in the hospital system, they didn't even properly support the MPIs. And we always required a diagnosis code in order to do the test. And we were receiving in the EMR interfaces in the comments field, the diagnosis code. So there was being stuck when the order would be tried to be released from the EMR. It just wouldn't go anywhere because it was a required field. Next. So what I quickly learned, and I could go on for about 3 days about all the pain is that when they were moving the project, it wasn't about all the cool features that the new system had or how it would work just moving all the data from the old system to new system, but it was really working with the vendor appropriately and understanding all the different workflows decisions, who own those decisions, having the vendor understand from the bench how it worked, from the outreach perspective how it worked. The reference lab interface was out of scope. So when we went from the new system, we weren't able to send to a reference lab vendor, which was very painful. It all went back to manual because they basically locked the code. And so I learned a lot, is like saying is you really have to sit with your vendors, understand all the different ways you get the orders, all the different ways you get the results, and or else everything's going to fail. As Gilad mentioned on his horror story was some of the final versus partial and how the tests were defined. Even that part broke. So some physicians were expecting partial results and not waiting for the final. And other physicians says, why are you sending me partials when I just want the final chart copy? So the executive impact was our call volume went up. We lost accounts, and we were on this great new system. but all the processes weren't properly vetted out, and it was a nightmare. And it took a long, long time to get the trust of the physicians back. Next slide. And so what should have happened? So this goes the part about with the partnership is that we really need to sit with the vendor and have true workflow ownership, and working with the LabOS folks when they were my client and I was a client of them is they truly own the process. It wasn't just a software setting configuration options. They really helped sit with our teams and understand how the whole workflow would work from the inception of the order all the way to the final result, all the downstream systems, the revenue cycle systems, all the operational and financial reporting. They really understand the lab business when it comes to that. It's important to name an operational owner for each of the processes, that someone has to own it. And if someone doesn't own it, it doesn't get done. I heavily from the lab side is involve the people that are the frontline, the bench technologists, because they actually know kind of where all the dead bodies are hidden, if you will. They understand their processes, and if they're getting buy-in through early in the process, they will be your best champions, even if there are problems after you go live. Exception path mapping. Every lab has made 1 million decisions before they're installing a new LAS. So it's good to understand all the different exceptions that they have, but they should also be aware of getting a new system. There's probably a better way of doing it. And then also, this is the big failure that we didn't do was we really need 30 days of kind of processing kind of in 2 environments. And then with a rollback plan, ours was basically rip off the Band-Aid and go live. It really hurt. Okay, next. Think about that. We could skip this for now, just for timing. Okay, so just quick wrap up. So I went to the horror story to talk about what you should be looking for in a good vendor is that they're not just selling software that's, you sign a contract and they're just going to ship something to you. You really have to have a good vendor, like the team at LabOS that understands processes. They understand how their technology can solve your problems. And it's really key to be open with your vendor. And this way, your success in going with the new systems, you'll look back and you'll be like, how do we do things before? And you won't care because your system will be working so great.
Right. Thank you, Jack. That's actually a good point. And before I give the stage to Gilad to give his 2 cents about that first point, I just want to mention to the people watching, I see some questions already in the chat, and I got word that we have some questions. Don't worry. Once we're done with this part, and I'll have some questions, then I'll read some of the questions in the chat. So if any of you watching still have anything to ask, please do that in the chat. Gilad, do you have anything to share about the first point that's written here? What should have happened in your horror story? You're on mute.
Sorry, I was again, mostly just again, the same part where we should have had the partner or recommended strongly to the hospital just to do some of that leg and research work before kind of hitting the ground running on the technical tasks at hand. So yes,
Now, before I move on to the second question that I wrote here on the screen, I just want to make sure that everyone is on the same page. The reason we chose the term horror stories is not only because the horror genre is so popular right now in the world, it actually always was. It's because everyone who's ever worked in tech knows some variation of these stories. We all have the horror stories, we all carry the battle scars. And yet, what I found is until someone hears someone else shares his story, we can't really draw the conclusions from our own experience. We need to sympathize with someone else and their horror experience, and then we're like, oh, right, that actually can happen. So, having said that, we all know that responsibility and shared accountability are all major and important terms, but when push comes to shove and when you actually need to be on the ground, where does responsibility realistically sit between technology partners? I mean, it's all nice and easy, but in reality, where does it sit? Jack?
Yeah, I like to say it really from the lab perspective, they really care about the outcome, right? They don't care about the bells and whistles, the layers, the technology, everything else. What they really care is the outcome, which is the patient first and keeping the physicians happy, right? So when it comes responsibility sits between the technology partners, it's first is the lab has to be very open with the vendor on what their expectations are, right? If they have a big outreach program, is it going to be on, as my horror stories were about all the interfaces? If it's more of a hospital that is very busy, inner city hospital, and they got to get the results through very quickly, it's really about, turnaround time. If it's a large national NGS laboratory, it's about the complexity of the report. So the responsibility is the lab helping the technology partner understand really what is important to them, and the technology partner listening to understand is what really are their key drivers, both from the physicians who basically are referring, as well as the internal management structure, what they're looking for while they change to you.
Right, cool. Gilad, you have anything to add?
Yes, I would just like to kind of call back, as Jack mentioned earlier, the ownership. If it's not owned, it probably won't be done. And I would say just better definitions of what each partner brings to the table, and that's definitely what they're owning and responsible for. Yes, definitely.
Totally. Let me ask you guys, the big buzzword of 2026 is AI, of course. But is it really the answer to all tech partnership challenges as we are promised? Is Elon right? When does AI become an actual challenge in itself?
So I'll jump on that first, just because AI, as we all know, is very heavily data driven, and more times than not, we find that the issue is with the documentation in the first place, and kind of all these half truth are just kind of I touched on it earlier, just a lot of the workflows that are not documented are just kind of in the air, or were trained, or someone, oh, go ask Felix, he knows all about that. So I don't think AI can really answer that at this point, meaning just to guess or go ask to find who's responsible for that process. So that's for the first part of the question. And when it becomes a challenge within itself, for now, it's definitely, I would say, a regulatory challenge. AI, just with the security and patient information and things like that, and implementing it again. I believe that probably that's the where it is a solution and a great. I mean, during implementation or for data that you do have to use AI tools just to kind of get manuals or get technical setups, I think that is a great solution. But again, it's a challenge within itself, and the partnerships, it can't work and help on things it just doesn't have access to, which is the human component of it.
There you go.
Jack?
Yeah. So I believe that AI works best in mature environments where you have a set defined problem right now. At Precise, we are solving one problem, which is manual paper recs. Labs cannot find labor at the rates that they wanted to. The price of just hiring just data entry folks keeps going up and up and up, and those folks don't even want to work at those second shift jobs. So we took a very simple problem, which was how to get these handwritten recs into an LAS system, very eloquently using AI, and it works great. We've seen some labs try to use AI to replace on the diagnostic part of it. And I go and sit through a lot of meetings where the pathologists are saying AI has a role, but they don't want to replace the pathologist. It's the pathologist license that's making the decision for the diagnosis. It can be used as a complement. I believe, you should dabble in AI and find a definitive problem, find the right partner to do it with, and expand appropriately. But just don't do AI for AI.
All right, thank you. I'm just letting the audience know that we're gonna skip the last two questions in the slide because I see that people are already asking something along those lines. So let's just talk about the last point, which is why modular API first systems outperform the monolithic ones, which in plain English means the legacy systems. Yeah.
Yeah. So it's pretty simple to see now. I mean, first of all, the technology is enabling us to release software and features a lot faster than the old legacy systems. The maintenance for them more is using open source, open code, AI, and just able to mix and match from different the strengths of the different platforms, the different APIs is much better than just a system that was probably developed and tailored for one legacy system where it was just and the people maintaining it. And these new API first systems where you can interact with the different systems and utilize each system's strength and strong points is definitely the way to go and to outperform someone who does something very well, but just that one task, and all the rest is kind of the price you pay for selecting that function.
Yeah,
Jack,
if I
you
can
have
make a
anything
quick
to add?
comment, the monolithic ones, they're just impossible to keep up to date, right? It like Gilly just said, they're always very custom, and there were any type of changes. It just seems like you have to go through a whole change cycle. Whoever wrote it the first time, you have to figure out who that was if they didn't write the proper notes. Where the API systems are much more malleable, easy to change, configure, retest, and keep moving. The world of, as my horror story was with the older EMR interfaces that have been out there for 15 plus years, they almost need to be thrown away. Test code directories are changing by the day, insurance carriers, new requirements for different types of data is just changing, and the older systems, they really need to be replaced. Problem is there's not a lot of dollars to change them, so sometimes the need don't always hit the economics, but that's definitely where things need to go.
Right, thank you. Now, again, I'm sorry for skipping the last two, but some of the questions I'm going to read in a second actually somewhat repeat those. So I'd rather let the audience actually ask them those questions, which, if you don't mind, I'm going to read. So there was a question on the chat that says, if I'm a lab manager, what is the single most important question I should ask a new vendor to make sure we don't become another horror story? So let's start with Gulab.
I'll take that. If I was a lab manager, then the most important question that I would have was to the vendor is, can you show me your failure log? Because we all make mistakes, but just a great vendor is one who knows how to learn from them and just get up and try again, and just to show the cycles and the precautions he took to avoid those errors from the past, and just build on for better in the future.
Good.
Amazing.
Yeah.
Yeah, do you have anything to add?
Yeah, because I was on the decision making a couple of different times for the major systems. First is what keeps a lab manager up at night is system reliability. So yes, mirroring your answer is your service level agreement on uptime, right? The system is constantly down. If you don't have proper change control, the worst thing, especially in a commercial lab, is you got to get the results out quick as possible. Systems have gotten much better over the years. So you hope your SLAs would do that. Also is domain experience is there a lab like mine who is using it very similarly, right? like our largest client, that's processing 10,000 paper recs a day is very different than a small commercial, a small lab outreach program that's only doing maybe 10 a day. They have different needs. So, to say is who else like me is using this system and can I scale to it? Don't underbuy a system just to save money, right? Because you want to be able to grow. The worst thing is you get there's a bunch of inexpensive systems out there. You use them for 2.5 years, and then all of a sudden you want to add a new department. You want to start bringing more tests in house, and then you realize you can't scale, or you're getting ridiculous fees. So pick a vendor that you can grow with as well.
Awesome. Now I'm gonna somewhat piggyback on what you just said, because there's a question that came in that's actually quite relevant to everything we just talked about. And it says, since every lab has its own unique way of doing things, how does LabOS and PreciseMDX keep track of these hidden rules without getting confused? Who wants to go first?
I can go first. Yeah. So any of our clients, we do a process and workflow assessment. And we basically say, you've made 1,000 decisions probably last week before we even showed up. Probably made a million different decisions. Like, how do you do it and why? Right. And the why is probably the most important part, because it was generally a workaround, because they might have had a system, the original SunQuest system, it's been out there for 40 plus years. So they might have been doing something because they had to do it. Right. And then back in my horror story, I talked about involving the bench folks, and that means the frontline people is going, what is preventing you from getting your job done better, and allow them to buy into the process, and then document it. Right. We often find that they are doing things that are kind of meaningless because they had restriction of the current systems. And if we were just going to replace everything they were doing before, then why get a new system? Fortunately with our AI, it's new, so we're giving them new process improvements. But we also have to do them gently, right? If someone's been doing the same thing over and over again for 15 years and you're asking them to get out of their comfort box, you have to do that appropriately. So the people that interact with our clients are very cognizant of change and change management. So it's both documenting it, understanding, and then obviously deploying it appropriately.
And I would just add that both platforms just have kind of an extended ruling mechanism where it's not hard coded. Jack just mentioned a system that's been around for 40 years, but we do things certain way, and the lab kind of gets, it's not a hidden rule to the question itself, but it's more like a workaround or a hoop that the lab just doesn't even notice it's jumping through and doing all these gymnastics to make something work, where if the system is customizable and programmable and just has a very good rule engine in the first place, then the implementation a lot of times detangles these hidden rules and very some, I would say, fringe workflows where lab managers sometimes don't even notice where they're doing this elaborate dance just to get from A to B, and it's just to kind of bypass limitations of the system.
Amazing. So basically, to sum up everything that we've just heard, whether it's the horror stories or the insights and the questions, we can all definitely. I mean, this slide doesn't seem that original, but again, when you actually take into account everything that we've just heard and everything that the audience knows, it is quite obvious that the old way should remain in the past. Whether it's vendor lock-ins and proprietary integrations, and of course the old-fashioned way of escalating chain of problem solving, all that should remain in the past, because the new way of collaborative ecosystems of tech companies and organizations partnering to be, let's say, co-vendors or, of course, partners, that's the way to go. Collaboration is the way to go, with open API first architectures and shared accountability. Once everything is figured out beforehand, that's the only way to actually give labs, and specifically medical labs, the best possible solutions available. I think that's quite obvious. Now, people who are watching this might see that this slide actually is quite similar to the ones that we showed in the beginning, because the questions that we asked in the beginning are the insights of this webinar, of this session. These are the main 3 points that we think every medical lab should remember: that reduced implementation friction and faster go live is possible through clear ownership boundaries and good communication. If you guys have anything to add regarding these insights or thoughts, I would be happy to hear. But I think it's quite obvious that communication between partners is key for success.
Great.
Yeah, if I could add just one point, I call it govern change management. And what I mean by that is you don't always want to listen to everything that a customer says. Is just because they have an idea doesn't mean that the vendor should run and do it. So what govern mean is take all the feedback from the front line, from the operations, and then run it through a process to say, okay, is this valid? Does this small change make sense? Does it help the overall organization or the code? So I say govern, right? And I say always have an adult in the room. Sometimes people just want to change, and then you're pushing back your implementation date, you're pushing back when you can go live. So you always have to have someone who is a good communicator, who understands politics as much as as systems. So I'd say that's key. And then also ongoing engagement post-implementation is like whatever your cadence is, whether it's, every day after go live, and then you go to every week, every other week with the QBR, but you have to keep talking to them, and don't always assume that they're not saying something, that everything's okay. There could be a problem that is really kind of festering, going up. And the worst thing is that you have your quarterly business review with the C-suite, and all of a sudden there's all these problems that come out of nowhere. And being a vendor, you could have responded much earlier to that. So it's constant feedback. Both vendors should look at the labs as partners, and the labs should look as their vendors as partners. We're all in this together. We all have either our family, our kids, our activities, and at the end of the day, we all just want to do the best possible job. And at the end, there's between every order, there's a patient waiting to get a result, right? And we're all just trying to do the best we can. So, leave politics aside. Just try to do the best you can. For everyone, and keep that patient in mind, and that is kind of what I think for the best success for partnership is.
Exactly. And on that note of open line of communication, and communication as the actual buzzword instead of AI, I just want to remind everyone who's watching this that you have Gilad's and Jack's details here on the screen if you want to open a line of communication to either one of them. And of course, I'm going to remind you again that this session has been recorded, so everyone who participated will get it directly in a few days. And in case you missed it, first of all, sorry that you missed it, but you're going to be able to watch it anyway through various channels. So just follow PreciseMDX, follow LabOS. And with that, I'm going to thank Gilad Brand. I'm going to thank Jack Redding for their time and their insights. And I want to thank you guys for watching, and have a great day. Thank you.
Thank you all.
Thank you all.
Bye.